Thank you very much for your kind presentation, and thank you, all of you, to attend this session. It's a pleasure for me to be here in Thailand, and I have to thank you, all the Society of the Thailand Radiologists, as well as especially Dr. Sup, and because it's his fault because I'm here today. And before to start with my talk, I just want to let you know that I'm here because I am an ambassador of the RSNA, that is maybe the most huge radiological society that we have in the world. And I'm here also to invite you to join the society. And as you can note, the fee is completely free for the residents, fellows, and students. And the colleagues from Thailand could have a very high reduction of the fee if they want to be members of the society. And I also invite you to attend the Chicago meeting, the annual meeting of the RSNA, because of its very huge possibility to have to receive credits and to acquire very new information of new developments in radiology. And of course, you can also attend online session by home. But now, let's start with the topic that you assigned to me. So, I have to say that, yes, I'm Italian, I'm not American, and I work in Italy. And I used to work in Cardarelli Hospital, that is one most huge hospital specialized in emergency in the southern part of Italy, and one of the most known hospital in Europe for the emergency radiology. But I recently moved to Pozzuoli Hospital as responsible for the GI, abdominal, and CT sections. But most of the cases that I show you today came from my experience in Cardarelli. Well, what are the objectives of this talk? Well, at first, I hope to teach you something regarding the physiopathology, or to refresh your notes regarding the physiopathology of the vascular disease of the bowel. Of course, I will show you some basic radiological signs of bowel ischemia and infarction, and we all together, we can better appreciate the cross-sectional imaging role in emergency. And of course, I try to give you some information regarding the different stages of disease in bowel wall injury caused by vascular disease. Well, at first, let's differentiate between ischemia and infarction, because there are two kind of different entities. Bowel ischemia itself may be caused by arterial occlusive disease, venous occlusive disease, as well as other low flow states from non-occlusive vascular disease. What about the pathophysiology? Let me give you some notes regarding that. What is the origin? What is the pathophysiology that attends, that are based and cause the reaction of the intestine by vascular injury? Well, I have to say that more than 1 century ago, Litten performed several experiments on dogs with ligation of the superior mesenteric artery, and he noted that the first reaction of the intestine was a collapse of the volutes, followed by hypotonia. And after that, if the ligation persisted long enough, intestinal infarction appeared. And of course, if there was a kind of reperfusion problems, the problems itself showed a very delayed, not just immediate, but the main consequences was, if not a good reperfusion of the infarction of the bowel. And these appearances were very, very similar to those that other scientists in the future years showed related with the human specimen. And of course, also the experiments of Masson in the 60s of the last century that evaluated the effect of the acute occlusion of the superior mesenteric artery confirmed the latent experience. And of course, after a very early stage of disease in which the bowel became cyanotic, with the disease progression, of course, the intestine began progressively necrotic, with evidence also of parietal pneumatosis. And of course, in addition to the injuries caused by ischemia itself, there may be an important component of tissue injuries done by reperfusion that could be evident after the early ischemic event. But what these notes could be useful for us, because using these notes, we can do a kind of a schematic spectrum of disease progression from a first stage in which the intestine reacts in a very neurogenic forms from spasm to hypotonia. And we could have a second stage of disease, the ischemic phase itself, that could be, that could persist long enough with no kind of reperfusion. That's what we will have directly, the infarction with the death of the involved segment of the bowel. But it is most commonly that we can observe a kind of reperfusion of the intestine with an intermediate phase that could, of course, they can become completely, disappearance of the problem with the healing of the intestine, but it could be worse, and we could have also infection of the bowel. Regarding the problems related to the impaired venous drainage, the occlusion of the superior mesenteric vein, of course, this kind of event can cause a slowing down of the blood flow. This consequence is the main intramural and mesenteric edema, and the necrosis and peritonitis are just complications of very long-standing venous thrombosis. So, that's why the evidence of a hypotonic reflex ileus that follows the initial spasm may be masked by the progressive and very evident intramural mesenteric edema to the superior mesenteric vein thrombosis. So many imaging findings related to vascular disease from impaired venous drainage of the small bowel are related to a marked mural thickening, mucosal hemorrhage, and submucosal edema. All these findings we will better appreciate with cross-sectional imaging. And also for this kind of disease, we could do a kind of a spectrum evaluation of disease progression, but you can know that spasm and hypotonia could be very, very quick. So maybe in most cases, we will image patients with, of course, occlusion of superior mesenteric vein in a second stage that could progress into chronicity or to go worse between infarction. But of course, that it is also possible to have the healing of the intestinal segment involved because of the superior mesenteric vein solvent thrombosis. What about the role of the MDCT? Well, nowadays, as we well all know, all people that is involved in emergency radiology well know, that because we have an increased amount of requests for the imaging for the acute abdominal symptomatology, and of course MDCT could be a very useful and effective tool to make a correct and effective diagnosis in our institution for this kind of request. We do not do any kind of endoluminal contrast medium in emergency, but in all patients we use the intravenous contrast medium because it is essential, because only the administration of the intravenous contrast medium could lead you to do a very effective diagnosis. In the direct suspicion of intestinal ischemia, we perform a multiphasic exam, pre-contrast phase, followed by arterial and at least venous phase. Just in several cases, we could do also an eventually late scan in in case, for example, in which we have a reperfusion problems, or in which we have to better appreciate if the bowel is okay or if it is a late stage of ischemia. And of course, we will adjust the imaging protocol and the acquisition parameters regarding the presence of the machine that we are using. And nowadays, for example, in our institution, we have a dual source, and we are only in the training to perform, a correct new protocol for this kind of machine. But generally, please use a very low slice thickness, and of course, the importance of back reconstruction with less than 1 millimeter images. But what to search for? Well, with this exam, we have to search at first for the patency, for the viability of the lumen of the mesenteric vessels. Of course, we have to look at the bowel wall feature, very important, of the evidence of mural thickening or thinning of the loops, and of course, the presence of the absence of the mural enhancement, the presence of distension by air and fluid of the intestinal lumen, as well as the presence of other findings such as the free peritoneal fluid or air, as well as the presence of spermatosis, either portal, mesenteric, or mural. We have to distinguish and to have very well clear that ischemia could be a very transient form that could be reversible, whereas this infarction, that means the very death of the loops, that is very important because the patient must be submitted to surgery immediately. What about the imaging findings? Starting with the disorders related from material etiology, as I already told you before, the very early phase is the spasm of the intestine, like in this case, in which you can know the occlusion of the superior mesenteric artery at the origin. But you can appreciate that the bowel loops are not infected, are not black, are just collapsed, so no air inside the lumen, the so-called acoustic abdomen without air inside the lumen. And bowel wall enhancement is very well preserved. The second phase is the hypotonia. It's hypotomia, and if the hypotonia of the bowel loops persists long enough, we have, of course, the stasis of the endoluminal content, like in this case, in which we have the thrombus inside the superior mesenteric artery, and these are the features of a just following second stage, in which you can know distension of the bowel wall loops, descend by gas and fluid, but the bowel wall is enhancing, so it's not infected, and it is well preserved. So also in this case, no need to submit the patient to surgery for resection of the intestine, but just because of the vascular problem. When there is, from the phase of hypotonia, when there is no reperfusion, I mean, if the ischemia persists long enough, of course, we will observe the intestinal infarction, like in this case in which you can know the absence of the parietal wall enhancement and, of course, the presence of parietal pneumatosis from infarction. When the reperfusion will be evident, well, main findings is related to submucosal edema, like in this case, in which you can appreciate the extensive thrombosis of the superior mesenteric artery and distension of the bowel loops by fluid, as most of the loops are preserved a very well appreciated enhancement, but some loops presented submucosal edema from reperfusion problems, like in this other case, in which you can look at the clot inside the superior mesenteric artery and the feature of the bowel wall, in which you can note parietal thickening, preserved enhancement, but submucosal edema from reperfusion symptoms. Also in this other case, occlusion of superior mesenteric artery and the presence of parietal thickening from submucosal edema. And in this other case, you can see just a reduction of caliber of the superior mesenteric artery, so no evidence of clot, and this is a case of ischemia, but non-occlusive ischemia, so I mean no obstruction of the lumen of the vessel, but just reduced caliber from. When the reperfusion will not progress with the healing, of course we have the intestinal infarction, and the situation could be very dramatic, like in this case, in which we have extensive portal mesenteric as well as parietal pneumatosis from infarction of the entire intestine as well as of the stomach. Regarding the disease caused by impaired venous drainage, as I already told you, the first stage could be very difficult to image for us because usually patients with submucous mesenteric vein thrombosis came to our attention with acute abdominal symptoms in a very more advanced phase of disease. Usually we will see findings like that ones. I mean, we can appreciate, of course, the presence of mesenteric vein thrombosis extensive and the evidence of parietal wall thickening of the small bowel with submucosal edema and mucosal enhancement. But also in this case, no need to send the patient to surgeon because with the medical treatment, like in this case, 3 months later, no need to be resected for the patients, and situation is very well because thrombosis is almost resolved, and of course also the appearance of the small bowel are complete with the restitutio ad integrum of the entire intestine. The first stage of disease, of course, it means much more over findings, additional findings, such as, for example, the mesenteric engorgement, like in this case, and of course the peritoneal fluid, and the evidence of much more thickened bowel wall, which enhancement could appear decreased, but in fact it is not, because it is just much more delayed with respect to the normal situation of a person in a healthy situation. But of course, in very rare cases, we could also have infarction from venous occlusion, like in this case, in which we have portal mesenteric splenic vein thrombosis with complete absence of enhancement from infarction of small bowel lobes. But let me show you some practical cases, like this one, in which you can appreciate thrombus at the origin of the superior mesenteric artery, but please check the appearance of the intestine, because of course we have also this extensive thrombosis of the superior mesenteric artery, but the enhancement of the small intestine is completely normal without any finding related to ischemia or infarction. So to have the presence of thrombus inside this SMA, it does not mean that patients must undergo surgery. So please be careful and look at all the bowel wall features. Whereas in this other case, you can appreciate something wrong, either in the vessels, either in the appearance of the small bowel, with complete absence of enhancement of the small wall forming extensive infarction. You can also note that there is just a small amount of peripheral fluid and no evidence of mural portal either or mesenteric pneumatosis. In this other case, you can appreciate extensive thrombosis of the superior mesenteric artery and the marked decrease in enhancement of some ileal loop distended by fluid, but no parietal thickening, no parietal fluid in this case. Well, the patient was submitted to surgery because of the ileal infarction, and in the postoperative, 2 days later, he developed a kind of abdominal pain. As you can note, the occlusion of the vessel was solved by Fogarty procedure, so now the vessel is okay, but some jejunal lobes appear like that. I mean, thickened, with signs of reperfusion, with submucosal edema and slight mucosal enhancement. With the pass of the days, of course, the reperfusion, if you will find a loop with a reperfusion appearance, you just have to wait and look at what situation we go further. In this case, 90 days later, you can appreciate the complete restitution ad integrum of the bowel wall appearance. So the patient was not submitted, of course, to additional intestinal resection. In this other case, you can appreciate something abnormal inside here, the mesenteric vein. And of course, we have the superior mesenteric artery without any kind of endoluminal defect of opacification, but just a caliber reduction, as some lobes were distended by fluid with endoluminal stasis, with a marked decreased or absent enhancement for infarction, as well as the presence of either portal as mesenteric and parietal wall permatosis. This other case, you can appreciate that something wrong inside here with the presence of the effect of opacification extensive of the superior mesenteric artery, just small amount of peritoneal fluid, but fluid distension of the vein with the complete absence of parietal enhancement from infarction. In this other case, related to extensive portal and mesenteric vein thrombosis, we have the alteration of the small bowel wall from imperious venous drainage, but with no signs of intestinal infection. Also in this case, no need to send the patient to the surgeon. Several days after the medical therapy started, you can appreciate the situation went well. So with the reduction of the symptoms of also the appearance of the bowel from impaired venous drainage problems. And 10 days later, situation was completely solved. Whereas in this other case, young patient affected by acute Bacteria syndrome, you can appreciate the amount of peritoneal fluid, and 2 days later, we can appreciate also a situation that progresses in a not good way because the bowel walls appear much more thickened with the kind of decreased parietal wall enhancement too, and the enhancement was completely absent in the next day with presence of parietal as well as mesenteric pneumatosis, and of course also of gastric wall from extensive infarction from venous disease. But at the end, let me give you some take-home message regarding the importance of an early diagnosis of intestinal ischemia. And look at this case in which we can appreciate the thrombus inside the superior mesenteric artery, either here, the multiplanar. And this is the appearance of the intestine. 3 days later, after Fogarty procedure to render the lumen patent once again, you can appreciate the findings of reperfusion, injury of the bowel, just a reaction of the bowel to the Noxa pathogena, but the parietal wall enhancement is very well preserved. And 8 days after, situation is almost disappeared. So I think that this is the end of this talk. I thank you very much for your kind attention.
Thank you very much, Dr. Romano, for the detail on pathophysiology of the bowel ischemia and infarction. Is there any question from the audience? Any questions? Okay. So I have a question. So when do you think would be the appropriate time to suggest surgeon that this is now infarction and not an reversible ischemia, and now you should go to surgery, and versus when we can observe?
Okay. In case you observe at first exam some reperfusion damage, you can just tell the surgeon to wait and take care about the abdominal symptoms of the patient, and to take care about the laboratory examination if the LDH will not go higher level in the next hour. Situation could be, just take that and observe. But if the patient will become symptomatic once again, you can perform another scan, maybe 24 hours later or 2 days later, and to look at the image of the involved small bowel. If the situation is okay, you will appreciate a reduction of the submucosal edema and of parietal wall thickening. If the situation will go worse, you can appreciate a major parietal thickening and decrease enhancement.
Okay, thank you very much. Any
You're
other
welcome.
questions? Okay, then we can move on to the next session. So the next session, or we should wait for a few minutes?
Yes, almost.
Okay, I think we can go on so that
Okay.
we will have time to ask more questions
Okay.
later. Okay, the next session would be about MDCT of intestinal obstruction.
Yes, thank you once again. So as all we know, under the title of intestinal obstruction, we included a huge variety of conditions which have the common property of bringing about mechanically an obstruction to the passage of matter inside the lumen of the intestine. Classically, we could have a different kind of obstruction. We could have a strangulation when the bowel is snared by bands or through hernias, for example. We could have an obstruction caused by torsion when the bowel is twisted, typically with the valvulus. Or we could have an invagination when the bowel is intersuscepted, bowel loop in loop. Or we can have an obturation when the bowel is blocked by something inside the lumen. Or we could have a stenosis when the bowel is narrowed by strictures or compression from without or parietal wall thickening from neoplasm. And also regarding the small bowel, the bowel obstruction generally, the most common imaging method that we used is the MDCT, as the CT nowadays. Although if in several centers, like mine, of course, in case of acute abdomen symptomatology, we still have requests from clinicians for sonographic exam and abdominal plain radiographs that could be useful, of course, to better distinguish and to better send to CT just patients with some positive findings and real imaging suspicion of something that is not good in the intestine, and that could be related, of course, to bowel obstruction. What about the imaging protocol? Well, it varies. It could vary, of course, regarding the type of equipment, CT equipment that you have in your institution. But generally, with the suspicion of bowel obstruction, we not give any kind of peroral or endorectal contrast medium. But in all patients, we administer intravenous contrast medium because it is essential to better define the appearance of the bowel, the eventual presence, of course, of a neck obstruction, but almost because with intravenous contrast media you can appreciate the presence of ischemic complications of the bowel. And of course, regarding the acquisition parameters, it's better to use a very low slicer thickness, and the presence of a back reconstruction with thickness less than 1 millimeter is essential to perform a very good multiplanar images, and for the processing is essential. Regarding the phase, well, in case of strict suspicion of bowel obstruction, you can limit the scanning to a pre-contrast followed by an enterographic phase at 55 seconds delay, because as all of you will know, the intestine, the peak of enhancement of the intestine is at that delay. But what to search for? Of course, in suspicion of a bowel obstruction, you can look at the presence of hair fluid distension of the intestinal loop, to the presence of a transition point, as well as of the potential cause of the obstruction either suggestive, either very well evident. But please look at the feature of the parietal wall, the parietal enhancement alteration, if any, or the mesenteric alteration. Look at the Will sign, the notch sign, all the signs described in literature, as well as the presence of free abdominal air or gas of the parietal, portal, or mesenteric pneumatosis. We could distinguish intestinal obstruction related to the small bowel or to the large bowel, starting with the second one. Well, I have to say that diagnosis, especially with CT of obstruction of the large bowel, is something not difficult at all, because of course the colon is not so long as the small bowel is. Like in this case, for example, in patients that was previously submitted to surgery in the past, we can appreciate the recurrence of the cancer of the transverse colon here, the cause of obstruction of the remnant of the colon and the small bowel. In this other case, the cause of the colonic obstruction was done by a neoplasm of the descending colon. And please note that, for example, the sagittal view of the exam leads us to a more accurate diagnosis and much more accurate definition of the neoplasia itself. And please also note the presence of parietal wall pneumatosis, but in this case, it's a benign pneumatosis, not done by infarction, but just due to the overdistension of the bowel when the air penetrates along some tiers of the mucosa, go through the submucosa, and of course have this kind of appearance. In this other case, you can also appreciate another neoplasm of the junction between sigmoid and descending. And also, if you have the presence of parietal wall pneumatosis, please look at the mesenteric vasculature. That is perfect. So it is not a case of pneumatosis from intestinal infarction, but just from overdistension. In this other case, you can appreciate the different findings. You can appreciate hair here in the portal system. You can appreciate the distension of the colon with a decreased enhancement, but not just of the colon, also of this intestinal lobes. And in this case, of course, we had pneumatosis, but was pneumatosis from infarction, from intestinal infarction, because in these patients presented some aberrant branches from the inferior mesenteric artery. These anterior branches went directly to the distal ileum. And you can also appreciate the inferior mesenteric vein pneumatosis from infarction. So this was a case of infarction of distal ileum and colon, not just something related to obstruction itself. Of course, you can appreciate, you can have as cause of large bowel obstruction, the valvulus especially of the sigmoid colon, like in this case, the typical coffee bean appearance of the twist sigmoid colon and the point of torsion. In this other case, the cause of the large bowel obstruction was a hernia, very well evident. But what regarding the small bowel? Well, diagnosis of the small bowel obstruction could be not easy and not immediate, and in fact still represents a difficult challenge either in diagnosis and therapy, because it patient with SBO present signs and symptoms similar to other acute abdominal disease that can mask the real entity and the real cause. What is the role of us as radiologists in SBO? Well, our role is very important, especially nowadays with the CT exams, because surgeons and clinicians ask to us if they must submit the patient to intervention, if there is any SBO, what is the cause, what is if there are any other complication. So we must evaluate all the findings and all the images from cross-sectional imaging in order to give important notes and information regarding the degree of obstruction, the site of the obstruction, the potential cause, as well as the presence of ischemic complications. Also regarding the small bowel obstruction, I can give you some notice regarding the physiopathology, because also more than 1 century ago, experiments on dogs led us some important information and indicated that there was a direct correlation between the manner of interference with the blood supply of the gut with the arterial blood pressure and the length of the segment involved with the obstruction with the potential complications. And especially, we must take care that when the veins and arteries are involved in the obstruction of the intestine, situation is, of course, not too different, but when the veins alone are tied, a gradual but definitely lateral fall in pressure occurs invariably. So this finding is much more related to infarction from SBO. And also in the small bowel obstruction, we can hypothesize a disease progression like this one. And the first stage is almost similar to the one that I just described because of the ischemia, because, you know, for any kind of noxa pathogena, the intestine reacts in the same way. First, spasticity, then hypotonia. And the second stage in which we are, we image patients with much more frequency, because it is in this stage that the patient usually came to us. And from the stage in which there is something that obstructed the passing of the matter along the intestine, we could have the so-called subocclusion, in which the situation is temporary, is not definitive, so the patient could have a kind of relief of the symptomatology and of the signs. But the disease could progress long enough, so we could have a real occlusion of the intestine that could progress into infarction of the intestine if the obstructions persist long enough. So what about the early stage of disease? Spasm and hypotonia, always the same. It is very, very difficult to image a patient in this step. In most of cases, we image patients in an intermediate stage in which the mechanical occlusion pervity follows a very early neurogenic cancer, like in this case. So in most of patients, we could appreciate this kind of findings. I mean, distension of the small bowel by fluid is not a massive distension, and this is a typical finding of subocclusion of the patient, in which the parietal wall has preserved enhancement, so it is not thickening, not thinning, it is almost normal. But if the obstruction persists long enough, we have a much more advanced disease, like in this case, in which we had much more evidence of intestinal distension by air and fluid. But also in this case, parietal wall could be almost normal, or just slightly thickening with submucosal edema. And the obstruction, when progresses, of course, interests many other segments, like in this case, in which you can appreciate almost all the intestine is involved and is blocked. But when the situation is not normal, when the diagnosis could be late, well, the diagnosis is very late if we image a patient with the complications, with infarction, like in this case, in which we can appreciate that there is something that is not normal. This lobe is completely black without a parietal wall enhancement, and the wall is thickened, despite the other one is, still presents enhancement of the wall. And this is the point of torsion in this small bowel volvulus. This is the exact and correct point of torsion of the intestine. And here you can appreciate the difference in enhancements between the infarcted lobe that is black with thickened wall, absence of enhancement, and the other ones that still presents a parietal wall enhancement. So in this case, the surgeon could do a segmental resection with, improvement of the patient's situation and life too. But let me show you different cases of small bowel obstruction, starting with this one. In this case, you can appreciate there is air where. The air is in the biliary tree as well as in the cholecyst, in the gallbladder. This is gallstone, in ectopic gallstone, is in the small bowel. And this is the fistula between the gallbladder and the duodenum. So this is a case of gallstone ileus, very typical. But you can have gallstone ileus also without the classic regular triad that I just mentioned. We could appreciate, like in this case, an ectopic stone in the jejunum. You can appreciate air in the biliary tree, air in the gallbladder, but of course no signs, and this is the specimen of the big gallstone, but no signs of a small bowel obstruction because the obstruction was very upper in the jejunum. In this other case, you can appreciate a gallstone here in the jejunum, but no sign of air in the biliary tree, no sign of air inside the gallbladder. But of course, you have sign of mechanical ileus, and you can appreciate the ancient tracts, fistular tract between the cholecyst, the gallbladder, and the duodenum. And it is important that if you will find a gallstone somewhere else along the intestine, it is very important that you make measurement of the diameter of all the diameter, because as you well know, if the stone presents one of the diameter less than 2.5 centimeter, well, this stone could have the chance to press to the ileocecal valve and to not need any kind of intervention. Well, let's change this other patient with, of course, just this image inside the lumen, slight hyperdence, also in this case, as signs of gallstone ileus. We just have the presence of a fistula between gallbladder and duodenum. But let's change. In these other patients, there is, of course, small bowel obstruction. But in this case, the cause is a neoplasm of the terminal ileum, distal ileum. This is parietal wall thickening from neoplasm. In this other case of small bowel obstruction, you can appreciate some loops affected by reperfusion symptom, appearance, and there is something wrong over here. And the cause of the intestinal obstruction, either in the absence of very dilation of the upper part of the small bowel, is the evidence of invagination. And this was the specimen from surgery. It was a gist. In this other case, this is the first exam of the patient with the slight acute abdominal symptoms and referring abdominal, impairment of the transit since some time. Well, I have to say that this first exam was reported as normal with no signs of disease. But in fact, the colleague did not take the attention to this loop that was distended by fluid. And it is not a normal finding. So please take care of all the findings that you can think that it is almost normal, but in fact they are not normal. Well, the patient still stay in the hospital because he was old. And 2 days later, his symptomatology got worse, and we make another scan, and you can appreciate the much more intense distension of the small bowel, and the same loop that appears to be distended by fluid now is distended by some other things inside the lumen. And imagine what? This is a case of a bezoar because the patient was too old and he has no teeth inside his mouth. So he completely swallow and orange slices without chewing it. So this is a bezoar caused by slice of orange fluid. And in fact, the cause was adhesion because when he was young, the patient was submitted to appendectomy. So in the right iliac fossa, there was an adhesion that caused, of course, obstruction many years after. In this other case, patient with acute abdominal symptoms, you can appreciate distension of the intestine by fluid. Situation get worse 2 days later. And in this case, you can appreciate a much more evident distension of the small bowel. And in some loops presented signs due to vascular injury, from impaired venous drainage and with submucosal edema. And in this case, the cause was the presence of a band. Other case of intestinal obstruction is done by volvulus. This is the pre-contrast. In this pre-contrast exam, you can appreciate some kind of hyperdensity of this loop. Is it normal or is it something abnormal? Well, the presence of spontaneous hyperdensity of a small bowel wall is not normal in any case. This patient had a volvulus of the small bowel with absence of enhancement of the bowel that appears to be spontaneously hyperdense, but this spontaneous hyperdensity was done by blood from necrosis of the bowel. In this other case, young patient, 15 years old, that presented to our attention after to be, have been in tour for other different hospital of the neighborhood without a complete and definitive diagnosis. And this is the CT findings. And we can appreciate, of course, portal pneumatosis, distension of the small bowel, and the presence also of parietal pneumatosis of what? What is this structure? This structure is the cecum. And the cause of destruction was something not too unusual in young people. It was a case of ileal cecal intussusception. And this is the finding, the surgical finding. So, sorry for that. Other case. Well, in this case, the patients referred some kind of abdominal symptomatology, very light and persistent in several times. And if you look at the exam, I will show you once again, it looks normal, maybe, but it was not normal because please look at the appearance of this part of the intestine. And look at the appearance of the multiplanar reconstruction and of the angiogram of the mesenteric vessel. There is something strange here. And in fact, it was a case of internal hernia. So also in absence of distension of the small bowel, please look at the appearance and the features of the bowel walls and of the bowel loops, and especially pay attention to the feature of the mesenteric vessels. In this other case, patient with acute abdominal symptomatology, you can appreciate here distension of the small bowel, some loops presenting some, slight hyperemia of the mucosa from signs of suffering. And this is the multiplanar coronal view. Also in this case, this was a transmesenteric hernia evidence. In this other case, this is the first exam of these patients, and please look at the feature over descending jejunal loops here as some kind of abnormalities here. This is a follow-up exam, and it still persists also if the distension by air fluid of the intestine was less than the previous exam. You can appreciate that something is not normal here. And in fact, also a very late CT scan, maybe 2 months after, still represent this. And this was a case of paraduodenal left hernia, internal hernia. Let me show you another case, another cause of obstruction. This is the first exam of the patient. And here, although in the absence of marked and effective small bowel dilatation, you can appreciate something wrong here, mesenteric engorgement and parietal wall thickening with signs of reperfusion. And if you think that in most cases in which you have just parietal wall signs of reperfusion of some kind of abnormalities without any sign of obstruction in the upper lobes, please hypothesize the presence of a valvulus, because in valvulus, mesenteric veins vasculature is much more compromised. So the first finding that you will appreciate, that you can appreciate, are those regarding to the imperious venous drainage of segmental lobes. And in fact, situation gets worse. Some hours after, you can appreciate signs of imperious venous drainage, much more evident. And this is the movie, in which movie you can appreciate, better appreciate the presence of the wheel sign, the torsion of the mesentery here. This other case, this is the first exam of patient previously submitted to surgery. You can look at this stomia in the left flank. But this is something abnormal here, over distension and some mesenteric engorgement. But you cannot appreciate a very huge and massive dilation of the small bowel. And here, if you perform a movie, you can appreciate here the torsion of the mesentery. Also in this case, this is a case of a small bowel valvulus. So please perform multiplyral reconstruction and please look at the loops in all cases. And this is the presence of the valvulus in a much more advanced phase made 3 days after. So, at the end, let me give you just some findings regarding a potential correlation between all findings from the cross-sectional imaging and the surgical correlations, like in this case, in which we have small bowel obstruction and different wall feature. We have an infected segment with complete absence of parietal wall enhancement, whereas the other ones presented a preserved enhancement. And this is the appearance from surgery. So, infarcted, ischemic, normal. Like here, infarcted, ischemic, normal. Other case, massive distension of the bowel, massive decreased enhancement of the bowel lobes from valvulus. And this is the appearance. Massive infarction of the small bowel and normal appearance of the bowel. In this latter case, you can appreciate small bowel lobes, hyperdense inside, but it is an hyperdensity done by blood inside by necrosis. And this is the presence of the band, mesenteric band that causes the obstruction. So, what is, at the end, the importance of an effective diagnosis? Why we as radiologists are important for the surgeons? Because of this. Let me show you this case, this last case. In this patient, we have obstruction from cancer of the right colon. The patient was submitted to surgery, and several days after, she presented abdominal pain. So in the post-op, we performed another examinations, and the findings were those one related to impaired, some reperfusion of the jejunum. And if you can look at the ileum, it appears black. You can appreciate that it appears to have no enhancement. So a potential diagnosis of infarction, massive infarction of the ileum was made by the colleague. But in fact, it was not quite correct because in the post-op operative phase, the peak of the enhancement of the bowel is a little bit delayed of 10-15 seconds. So the correct parietal wall enhancement is not 55. So despite the diagnosis, the radiological diagnosis of intestinal infarction, the surgeons prefer to wait and see And they did well because, in fact, several days after, situation get better with the loops that appears to be black on the previous exam were not black, in fact, were presented normal enhancement. So this was the case of low flow postoperative complication with hyperfusion damage, but without any signs of infection. So please take care to do a very late scan in case of post-op intestinal patients. So in conclusion, of course, after the first basic imaging findings, there's just the CT examination that could lead us to perform a very good and correct diagnosis, cases of small and large bowel obstruction, especially regarding the findings related to complication by ischemia of infarction. I thank you very much once again for your kind attention.